Welcome all to another episode of Is Pharmacology Difficult Weekend Classroom. And today is 18th of October, and the last class we had on was last Sunday. And I just somehow managed so that I don't miss this weekend classroom this Sunday. So, as we always do in weekend classroom, as you all can see in the slide, we just revise, examine, and we learn. So, the purpose of the weekend classroom is to go through the summary of all the episodes from Monday to Sunday of the podcast episodes that have been done throughout the week. I'll try to summarize everything, but still, for the details, you have to refer to the episodes on my website, ispharmacologydifficult.com. So, without any delay, let's start with the first day of the week, and that is Monday. Now, continuing with the last class on Sunday, on 11th of October, on Monday, we did the dosing schedules basic concepts, part 1. And in that we covered if the half-life of the drug is about 24 hours, then what in that particular case, how the drug administration should be done and what concept has to be followed. So, I'll just let you know what all have to be done when the half-life of the drug is 24 hours. For the drugs having half-life of 24 hours, half of the therapeutic dose is given at every half of the half-life. And I explained that with a beautiful example of a drug having initial dose of 50 milligram and the half-life of 24 hours. So for that drug, you have to give 25 milligram every 12 hourly. That is half of the therapeutic dose. That is half of 50 milligram is 25 milligram, and at every half of the half-life. And half of the half-life of 24 hours is 12 hourly. So the answer becomes 25 milligram every 12 hourly. So that was the most important concept for the Monday. And then we also did something more. And then I covered in the second point was that if the half-life is too long, that is volume of distribution is very high and the rate of clearance is very slow, then what all we can do about such drugs. Very good examples are digoxin, desipramine, diazepam, digitoxin, etc. So in such cases, definitely the steady-state plasma concentration would be achieved in 4 to 5 half-lives. So should we wait for such a long time, or what should we do? Well, that was a suspense that I kept for the next day. So that was all for Monday, and moving on to our next episode now. Now, coming over to the Tuesday episode, I continued with the discussion that was left over on Monday, and especially talking about the drugs having too long half-life. In that particular case, see, the steady-state plasma concentration is achieved in around 4 to 5 half-lives. But it is practicable. Is it acceptable to wait for such a long delay? Well, it depends on the clinical situation. If there is no clinical emergency, as in case of anxiety or depression, then definitely we can wait for 4 to 5 half-lives and the drug to take over its space to achieve a steady-state plasma concentration. But if there is a clinical emergency, as if congestive heart failure along with atrial fibrillation, or there is hyperpyrexia and malaria, then definitely we have to fasten up the pace of the drug to achieve a steady-state plasma concentration. Now, what is the basic route of administration? What is the basic mode of administration when we have to achieve quickly the steady-state plasma concentration? For that, we have to follow a two-phase dosing, and initially we have to give a loading or priming dose, and then we can give a maintenance dose. The details I won't be covering in today's episode of Tuesday. Rather, I'll be taking them later. First of all, in the episode, I will again talk about one more important thing, and that is the basic objective of the dosing schedule. What is the basic objective of the dosing schedule? The first objective is to specify an initial dose. Whenever we have to quickly come to the steady state plasma concentration, we have to achieve that particular state. Then we give a loading or the priming dose. In case of few drugs that take a long time to achieve a steady state plasma concentration, and that is the first objective, that is to specify an initial dose for such drugs. Then the second objective is to specify a maintenance dose. Well, that is equal to the initial dose for most of the drugs, but sometimes it has to be remodeled also, it has to be modified. It may be equal to the half of the initial or the priming dose. I also gave the definition of the loading dose in this particular episode, and that was the dose that would achieve a therapeutic effect in an individual's body which does not contain any drug. So, that was all covered in today's episode of Tuesday. Now, whether these objectives of to specify initial dose and to specify a maintenance dose, these are effective and they are practically acceptable, this particular whole thing depends on the T half of the drug itself. Well, I've covered so many cases, and in the next episode, that is on Wednesday, I'll be covering few more cases. Till then, let's go over to the Wednesday episode. Well, welcome to the Wednesday episode. In today's episode, I will be continuing with the discussion left over on Tuesday because we are still doing a series of these episodes and they are all interconnected. So for Wednesday, I just left the discussion of more cases to specify the maintenance dose. In that particular case, the first of all that we will discuss for the Wednesday is if a drug has a more than 24 hours of half-life. In that particular case, if you give maintenance dose as half of the initial or priming dose, and then if the drug entering is more than the drug leaving, then it will accumulate and it would lead to a lot of unwanted side effects. So what is the solution for that particular case? In that particular case, we have to make a dose available that would leave the body in 24 hours. And that can be calculated with the help of dose interval, and plasma half-life of the drug. So that is the first concept for Wednesday. Coming over to our next case for the Wednesday. Next case is if the half-life is less than 3 hours, especially in case of dopamine, and then you have to give the drug by continuous IV administration. Sometimes the half-life is longer. In lidocaine, it's 90 minutes. In that case, we have to give the priming dose as an intravenous bolus, and then it is followed by a constant intravenous infusion. So that is a little modification that we discussed earlier. Now, another new thing I wanted to talk about to all of you on Wednesday was that intermittent administration of a dose with small t half is quite acceptable if the fluctuations in the plasma concentration are not much large, and they are quite reasonably acceptable, because sometimes it's quite risky to give intermittent administration of a drug dose, especially if the plasma concentration fluctuations are very, very large. So a drug should have a large therapeutic index, and a very good example I gave you was of benzyl penicillin. So these were some new modified concepts that I discussed on Wednesday along with the wonderful examples. Moving on to our Thursday episode. Now on Thursday episode, I talked about a new thing, continuation with the topic of the dosing, schedules, basic concepts we have finished on Wednesday, and today we started off with a new thing that was loading dose and maintenance dose. So I broke the ice of the particular episode with the definition of the loading dose, and it goes on like that. A single or few quickly repeated doses given initially to attain a steady state plasma concentration is known as a loading dose. And I gave you a formula for loading dose, and the formula is target steady state plasma concentration into volume of distribution whole divided by bioavailability. You can see on my side I've abbreviated with the right abbreviations and I've written the formula. So with this, we get to know that loading dose is governed only by the volume of distribution and it is totally independent of the clearance. Well, coming over to the concept of maintenance dose, I talked about it that the maintenance dose is a dose that has to be repeated at specific intervals after the attainment of steady state plasma concentration, and it does depend upon the clearance of the drug. Now, that is a dose that balances the administration of the drug and also the elimination of the drug. That is why it is known as maintenance dose. And because it depends on the clearance of the drug, it also depends on the plasma half-life, that is T half of the drug. Now, this whole thing, the concept of loading dose and maintenance dose, is referred to as two-phase dosing. And this two-phase dosing is applied in cases of drug like digoxin, chloroquine, etc., having a very long T half. Now, as you all know, we have got that information that this two-phase dosing is particularly useful for the drugs in case of emergency. If there is no emergency, then definitely you can use the maintenance dose as an initial dose only. So the concept of two-phase dosing is particularly applicable in the case of emergency. And what are other cases where it can be applicable? I told you that also. In case of drugs having short T half and they are critically ill patients, that is lidocaine in the use of cardiac arrhythmias. In that particular case, an IV bolus dose is given as a priming or initial dose, and then it's followed by the maintenance dose. And then before ending up the topic on Thursday, I just gave a little sneak peek in the discussion about the monitoring of plasma concentration of drug. Now, what is the need of monitoring of plasma concentration of drug, especially when the drug has a narrow therapeutic index? Now, what I discussed in monitoring of plasma concentration was that the steady-state plasma concentration of a drug, it depends on the volume of distribution, clearance, and bioavailability. Now, all these parameters, capital V, capital F, and capital CL, they vary among the individuals. And what we derive as the average CPSS, and what we derive these values of the average patient calculated from the population data, they are quite different from the real values. So we get a formula of the revised dose rate. And what is that formula? The revised dose rate is equal to previous dose rate into target CPSS whole upon the measured CPSS. So that is a new formula. With this new and big formula, I ended up the episode of Thursday. Nothing more to discuss on that day. So coming over to our next day. Now coming over to the Friday episode, I talked about few important concepts about the loading dose. Before directly going into the details of the last topic I left, that is monitoring of plasma drug concentration, I wanted to finish up the loading dose and the maintenance dose completely so that we can really get into a new topic details nicely without leaving anything behind or without leaving any leftovers or backlogs. So to start off with the episode, I just discussed a beautiful example of chloroquine. Now, what is the need of loading dose and maintenance dose concept in chloroquine? First of all, because it has a very long T half, and secondly, because it has a tendency to accumulate in the liver that further delays the clearance of that particular drug, and so it does need an initial loading dose and a nice maintenance dose. So that was the first fact about the loading dose I gave you on Friday. The second fact I gave you all was sometimes the drug may have very short T half, but we do follow this two-phase dosing, especially in case of lignocaine, and that is in case of cardiac arrhythmias because it's an emergency situation. And we cannot take the risk, we cannot take the chance of waiting for the drug after 4 half-lives to attain a steady-state plasma concentration or to show its effect. So that's a very difficult thing and very risky thing. So better go for an initial loading dose and then go for a maintenance dose. And then the last loading dose fact I gave you was regarding some of the antimicrobials and antibiotics, sulfonamides, doxycycline. In their case, why do we need a two-phase dosing concept? Because their concentration needs to be maintained above the minimum inhibitory concentration, because if it's not maintained, then it may lead to antimicrobial resistance. So to just stop the development of antimicrobial resistance, we need to give an initial loading dose that would quickly achieve the steady-state plasma concentration. Okay, so these were the 3 important facts of the loading dose that I discussed on Friday. Now, I also ended up with a little deviation from these normal healthy people facts of loading dose. Before winding up the topic on Friday, I discussed about in case of the patients of the renal failure. In that particular case, we need to have a concept of corrected dose. And what is the formula I gave you for corrected dose? Just see on my side also, and I'll repeat it here also. And it says that corrected dose is equal to normal dose into the ratio of patient's creatinine clearance upon the normal creatinine clearance, that is 100 ml per minute. So with this multiplication of the normal dose with this ratio of patient's creatinine clearance and the normal creatinine clearance, that is 100 ml per minute, we can calculate our corrected dose, and that is applicable in the cases of patients of renal failure, where these normal calculations, they are not actually showing the right results. So that was another modification. And lastly, I wanted to tell you that scenario changes always occur. So just don't go by the mathematical things. Keep your eyes open and do see for the other clinical emergencies and observations and conditions that you observe while actually treating a patient, because theory and mathematics don't really apply to the real life. So they have to be merged together. Your concepts have to be applied, keeping in mind all the clinical situations and the therapeutic emergencies and observations. So always be vigilant and always stay informed about the new things and keep yourself updated. Then coming over to our start of the weekend, that is Saturday episode, I talked about a new particular thing, that was therapeutic drug monitoring. Yes, we started with this. Actually, it's a sort of a part of the monitoring of plasma concentration of drug, but it in itself is a very important topic as far as questions are concerned, objective, subjective, anything. And this is abbreviated as capital TDM. So on Saturday, I told you what drugs and which situations require the therapeutic drug monitoring, especially when a drug has a low safety margin. And what are these drugs? Anticonvulsants, antiarrhythmics, then we have theophylline, then we have aminoglycosides. So these are the drugs that I gave you more drugs in the list. They are listed on my side, you can see. So the first basic need of therapeutic drug monitoring is when the drug has a low therapeutic index. That is, it is not a very safe drug. Second, I told you when the individual variations are large, and that occurs especially in the case of antidepressants and lithium. Then the third case when we need TDM is potentially toxic drugs or poisonous drugs in renal failure, and very good example is aminoglycosides. Then fourth one in the case of poisoning. Fifth one, when the drugs fail without any good reason, and that occurs especially in the case of antimicrobials. And last but not the least, the most important need of TDM is to check the patient's compliance, and that in the case of psychopharmacological agents. So I also told you a little initiative aspect of the next episode that I was about to do on Sunday. I hope it's not yet released, but I will definitely do it on Sunday. Why do we need different purposes? Why do we need to study the different purposes of therapeutic drug monitoring? Because the correct interval between the administration of the drug and the collection of the drug sample for the TDM, it depends on this particular purpose of TDM. And it also depends upon the nature of the drug itself. So for this particular reason, we need to study the different purposes of therapeutic drug monitoring. And that will be covered in the Sunday episode. Now, on the Sunday episode, I started with the real purposes of therapeutic drug monitoring. Well, the first one is when you have to monitor the dose adjustment and when you have to vigilantly look for the dose adjustment, especially for the drugs that act continuously. And in that case, you need to go for the trough steady-state plasma concentration. What do I mean by saying trough steady-state plasma concentration? That is just before the next dose. That is the concentration just before the next dose. And it depends upon the volume of distribution and also upon the clearance of the drug. Sometimes for short-acting drugs, they achieve the steady-state plasma concentration with the intermittent dosing. So in that particular case, the sampling for the TDM, the sample collection for the TDM is done in the post-absorptive phases. And what is the post-absorptive phase? That is 1 to 2 hours after the oral or IM administration of the drug. And that actually reflects the peak level of the drug. So that is a different case. That is for a drug having short T-half and intermittent dosing. Okay, so that is the first purpose of the therapeutic drug monitoring. Now, what's another purpose of therapeutic drug monitoring? Now, in case of poisoning, we need to do therapeutic drug monitoring. It's very important. Why? Because as soon as it is done, it's the best part because it tells the extent of the poison, how much effect it has done, is it serious, is it not serious, how much damage it has done, how much peak concentration in the plasma it has achieved. So that all needs to be done, and that can only be done by therapeutic drug monitoring. And then we have to keep on repeating the therapeutic drug monitoring in the person in case of poisoning, so that we get to know the clearance of the drug, we can hasten the elimination of the drug, and there's so many things that need to be taken care of in case of poisoning. All can be known only with the therapeutic drug monitoring. And the last purpose of therapeutic drug monitoring is to check the compliance of the patient. And for that particular purpose, random sampling can be done. It is quite informative. You don't need to go for a specific sampling, specific time of sampling. You can randomly do sampling and get to know the patient's compliance of the drug. And that's the last purpose. That's the most important of the last purpose of the therapeutic drug monitoring. Well, with that, we winded up the weekend's episode. And before we start off the new topic for the new week, I would just like to say that in case you have not attended the episodes, please go and listen to the episodes on ispharmacologydifficult.com because they cover all the details. And in the end, I would just like to say that these are my links to different places where you can follow and you can get new updates. So that's all for this particular week. Take care. Bye-bye. Thank you.